Welcome and thank you for joining us today. This telehealth series is presented by the Now New Mexico Quality Improvement Initiative, an initiative that focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for care consultations around this focus. And today we have two presenters. Our first is Dr. Heather Pratt-Chavez. She's our physician champion for the project, and she's an associate professor of pediatrics in the Department of Pediatrics at the University of New Mexico School of Medicine, where she's been with them since August of 2010. She is an expert in the care of neonates with opiate exposure and withdrawal symptoms. And we also have with us Dr. Emily Sebesta. Dr. Sebesta graduated from the Johns Hopkins School of Medicine in 2001 and completed her pediatric residency at the University of New Mexico in 2004. She is a professor in the General Division of the Department of Pediatrics at the University of New Mexico, and she has co-directed the Mother-Baby Unit and Newborn Nursery since 2010 and has been instrumental in improving support for breastfeeding mothers, including spearheading the effort to make UNMH a baby-friendly designated hospital. She is the American Academy of Pediatrics Chapter Breastfeeding Coordinator for New Mexico and has worked with the New Mexico Breastfeeding Task Force for many years to help support breastfeeding families and provide breastfeeding education to medical providers. Thank you for joining us today.
Thanks for having us. And Emily, I just want to tell you thanks again for doing this talk. When I talk with providers in the smaller community hospitals, they have a lot of questions about supporting moms with breastfeeding and when breastfeeding should be supported for this population. So thank you for talking on this topic.
You're welcome. It's my pleasure.
So when you're ready, we can.
All right. So I'm going to talk a little bit about breastfeeding in moms with substance use disorder or even moms using substances who may not actually have what we would call a substance use disorder. So my objectives today are we're going to review very quickly the basics of drug transfer into human milk. And I would like for people to leave understanding a little bit about what the current recommendations for breastfeeding with moms who have opiate use disorder are, and then be aware of some other issues affecting breastfeeding success in mothers with opiate use disorder. So one of the take-home messages is that contraindications to breastfeeding are rare. So the default should really pretty much always be that when in doubt, allow the mom to breastfeed, at least until things are sorted out. And especially in the first couple of days of life, babies don't get a lot of milk. The mom makes colostrum, and so there's not going to be a lot of exposure. So there's time to go through records or get records sent to you and figure things out. Although, of course, it's always important to let a mom know that your decision may change. So real quick, and the theme for this slide is bigger is better. So the three most important factors affecting the medication or drugs concentration in breast milk are volume of distribution. So if it's distributed more widely throughout the mother's body, there's going to be less concentrated in the milk. Second of all, maternal protein binding. So protein binding more than 90% is really good. So if it's bound up to mama's proteins, it's going to have a hard time getting into the milk. And molecular weight. So molecules that are really, really big are going to have a hard time passing from the bloodstream into the milk. Log P is something that I don't really understand terribly well anymore, but suffice it to say, if it's water soluble, it's less likely to concentrate in breast milk. Okay, so if it's lipophilic, if it loves fat, it's going to concentrate in the milk. And then two other things that are calculated, and we don't have to do it because lots of other people have done this for us, milk to plasma ratio. So if the ratio of a drug in the milk is compared to the mom's plasma is less than 1, it's usually safe. And then something called the relative infant dose, which is just looking at the weight-adjusted dose for the baby. If it's less than 10% of the maternal dose, it's typically considered safe. So finally, bioavailability really matters too, because even if a medicine can go into the breast milk really freely, if it's going to get broken down in the baby's gut and it's not bioavailable, then it's not going to enter into the baby's bloodstream. A good example of that is heparin. Heparin's not going to go into the baby's bloodstream. And just a couple of tips for reducing exposure: avoid nursing at times of peak drug concentration, and when possible, look for drugs with a short half-life. Cocaine, just a quick plug, cocaine and PCP have really, really long half-lives and they're metabolites, so they're particularly dangerous to infants, so we really don't want moms who have been using cocaine or PCP to breastfeed. And then, of course, it makes logical sense as the baby gets a little bit older. If there's a drug that you're giving to the mom, administer it before their longest sleep period. So what resources can you go to if you have questions? And Dr. Pratt, Chavez, or I are not there to answer your questions. So the two main ones are, one, LactMed. This is free. You can get it on your computer. You can download it onto your phone for free, the app. And it gives a lot of good information, and I'll show you a couple of examples later. And the second is Medications and Mother's Milk by Thomas Hale. This is a book. You can purchase the app, and of course it changes every year because he pretty much comes out with a new book every year. I tend to, when I'm having a real quandary trying to figure out, mom's on several medications and I'm trying to figure out, will this work or not, I tend to look at both. But my number one go-to is LactMed. So I'm just going to kind of go through a case. So you have Miss Smith. She arrives on the postpartum floor. She's a 2-hour-old AGA baby girl. She's 28. This is her first baby, and she has a history of polysubstance abuse, but she's been in a methadone maintenance program for 2 years, and she would like to breastfeed. So what do you want to know? Obviously, this is typically interactive, so I'm just going to kind of answer the questions, but some of the things you might want to know are, did she get prenatal care? And I apologize, it's up in the purple, you can't see it. Did she get prenatal care? Is she in a treatment program for her drug addiction? Has she had urinary UDMs throughout? She had urine drug screens throughout her pregnancy, and if so, what are they? Does she have any infectious diseases we need to consider? And is she taking any other drugs, whether she's using illicit drugs or is she taking other medications and other medications? So you're going to take all of those things into account. I'm going to digress for a second and talk a little bit about why we are having this conversation and why Dr. Pratt Chavez is working on this. And I think she's probably spoken about this before, but we know there's an epidemic of maternal opiate use. This only goes to 2009. Based on everything I've read, I imagine that curve is going up at either the same rate or perhaps even faster, steeper. So as a result, following close behind, neonatal abstinence center going up at the same rate. And this is kind of interesting. So, a lot of our problem is because of the prescribed medication. So prescribed opiates. So you have oxycodone, you have hydrocodone, you have morphine. Methadone's down here. Obviously, as these go up and moms become addicted and either start using heroin and then need to go on to methadone or buprenorphine, or go directly from one of these to methadone, the methadone line is going to increase as well. So here's your, this is just showing the interplay between the two. So prescription opioids have been going up over the years. They peaked and now they're going down, but as you can see, heroin use is going up because heroin is much cheaper. So as this goes up, that creates lots of problems for us. And this is becoming more and more a woman problem. Interestingly, men are using less and less opiates and women are using more and more. So this was something that was in the New York Times in 2011, showing the baby getting their methadone or their morphine. And this is 2017. So you can read about a tide of opioid-dependent newborns forces doctors to rethink treatment. And that's what I want people to focus on, is that, we were thinking of it as this is a problem we need to treat with medication. And now we're realizing this is a problem we need to treat with how we need to change our care and what we're doing for these infants. And breastfeeding is part of that. So our experience, we have, and this was actually a couple of years ago, we had approximately 180 infants per year with born to moms using chronic opiates. That's 6 to 7% of all of our babies. And I suspect that's probably higher now. Heather, so, do you know?
I don't have the most current data, but I will add that into one of our talks.
This was from either 2 years ago or 3 years ago. So I know it hasn't gone down. It's either the same or it's gone up. Mm-hmm. So what do the experts say about breastfeeding? Well, the AAP, the American College of Obstetricians and Gynecologists, the Academy of Breastfeeding Medicine, and I should have put on here as well the Academy of Family Medicine, everybody supports breastfeeding for moms who are on opioid replacement therapy. As long as they are in a stable treatment program, they've had consistent prenatal care, they don't have another contraindication to breastfeeding. They've had negative urine drug screens for the last 90 days and at the time of delivery, and that's not 100%. We'll talk a little more about that. And then they're able to continue to abstain from using illicit substances. But everybody agrees that it is okay. And that has not always been the case. I believe it was 2001. It may have been a little later when the AAP went from saying if a mom was taking 20 milligrams a day or more of methadone that she couldn't breastfeed. And now it doesn't matter what the dose is. If a mom is on methadone or buprenorphine, it's okay. So breastfeeding, and expressed breast milk, the jury's out. It decreases the need for pharmacologic therapy. It decreases the severity if the baby does have neonatal abstinence syndrome, and it decreases the length of stay. So breastfeeding should be one of the go-to things that we are doing for these babies when the mom is eligible to breastfeed. This is a far better treatment than just giving babies medication. So another reason that this is so important is that, not only does it decrease the incidence and the severity of NAS, but babies who are born to moms who have been using opiates throughout the pregnancy have a very increased risk of SIDS. One study I read said 74 times the risk of SIDS, and we know breastfeeding reduces the risk of SIDS. There may be an association with a decreased risk of postpartum depression. That one's a little fuzzier. It's not clear whether people who are not depressed breastfeed more or whether the breastfeeding tends to prevent depression. I think there's probably a little of both. We know with oxytocin release that people feel more relaxed and they feel better and they have more, positive thoughts towards themselves and their baby, so it stands to reason that it would help with depression. Increased bonding, of course, again with oxytocin and that time of being close to your baby, and potentially a decreased risk of relapse. And that's been talked about in several places. Less so, I think the evidence in the past has been that if you have a mom who's actively using, that it's unlikely that giving birth is going to make her all of a sudden clean up her act. But for the moms who have been in a stable program and are doing well, there's good reason to think that this is going to lessen the risk of them going back to using illicit substances. All right, so case continued. So Ms. Smith is enrolled in the UNM Milagro program, which I'm sure many of you, if not all of you, know what it is. It's a program that moms who are pregnant are followed, and they receive, they have social work, psychiatry, and it's a group of doctors and nurses who are trained to work with these moms and really support them in their pregnancy. So she started her prenatal care at 18 weeks. She's had 7 visits. Her UDMs have been positive for methadone, and they were positive for marijuana at the first 2 visits, but since that time, they've only been positive for methadone. And she's hepatitis C positive. So is it okay for Ms. Smith to breastfeed if she's hepatitis C positive?
This is a great question that we just were discussing with one of our community hospitals.
Yep.
Mm-hmm. So, yes.
Yes, it is okay. In rare instances, it's not okay. So, some other things you want to think about when you're thinking about Hep C, and we'll talk about this a little bit later in other aspects as well, but it's guilt and fear. So there's a lot of guilt on the mom's part, typically, and fear that her baby's going to get hepatitis C from her. So you have to think about that. You got to think about, what is her spouse or her partner thinking? Are they afraid that mom's baby's going to get hepatitis C? And, are they pretty judgmental about this? Family's fear and judgment. So there's a lot of stuff that goes into it. The last one is the medical one, bleeding nipples. This is really the only contraindication. If mom has bleeding nipples, she shouldn't be breastfeeding on that side. Okay, she can breastfeed on the other side, but she shouldn't breastfeed on that side. And hopefully, if we are doing our job supporting moms in breastfeeding, they're not going to get to the point of having bleeding nipples. So what if her UDM was positive for amphetamines? So no, amphetamines, cocaine, and PCP are pretty much considered to be absolute contraindications. We already talked a little bit about cocaine and PCP with the long half-life, but amphetamines as well. So typically a no-no. This is a busy slide. I'm not going to go into it. I think in some way, the 2 most important take-home points from this slide are, 1, everybody should have, for their hospital, their own substance abuse and breastfeeding guideline. And this is ours, and you're welcome to borrow it. We can give it to you if you would like it. So the guidelines that we have implemented and follow say that if her tox screen has been negative for 90 days prior to delivery and at the time of delivery, and she's planning to not continue to use illicit drugs, and she has received consistent prenatal care, we're going to support breastfeeding. So what if she was getting buprenorphine instead of methadone? So I already alluded to this and said, yes, it's fine. It is fine. The amounts of methadone or buprenorphine passed into the breast milk was very, very small, regardless of mom's dose, and it's considered safe. I was reading one article and it said that, and I need to check, but the buprenorphine package insert, I believe, may say from the manufacturer, not advised to breastfeed, but there's been lots and lots and lots of research showing that it is absolutely okay. Infants exposed to buprenorphine via breast milk are going to get a relative infant dose less than 1%. And if you recall from my earlier slide, less than 10% is considered safe. So it's very, very small. And in part, this is because it's really highly protein bound and it has really low bioavailability. That's why buprenorphine is sublingual. So the chances of this getting into the mom's milk and then the baby actually getting into their serum are really low. So again, if a mom is using methadone or buprenorphine, they're fine to breastfeed at UNM so long as they're not using other drugs of abuse and they're in a substance abuse program. We also really, I think this is important that for the prenatal providers, that they do note in their prenatal care that they believe the mom is a good candidate to breastfeed or not. I also think it's good for the provider taking care of the baby to write a note to that effect. Sometimes you may need to put an order in, especially if you have nurses who aren't as familiar with these babies. But I think it's always good to document that these are the reasons why you are supporting breastfeeding for this mom. So this is what happens, and I'm going to diverge a little bit into some of the other issues for these moms and babies. So Ms. Smith's provider and the pediatrician encourage her to breastfeed, and every time she tries to breastfeed, she's unsuccessful latching the baby. She keeps asking for help, but whenever the nurse or lactation specialist comes in and tries to help, she says, well, I think I'm just going to give the express breast milk or formula in a bottle. So needless to say, her nurses get really frustrated, and they're starting to say, well, I don't think she really wants to breastfeed. And reading some of this literature really made me think about when I encounter these patients, what am I not finding and what am I not looking for? And I'm going to change my practice. So one nurse tells Ms. Smith it's her fault the baby won't latch because her opiate use caused the baby to have NAS. It's never a good thing to say. I think we have to be really careful when we talk to all of our families with breastfeeding. I think it doesn't take much for a mom to feel like we're saying you're doing it wrong or this is your fault. But I think with this particular population, they're just way increased vulnerability for a variety of reasons we'll talk a little bit about later. And then at the 2-week visit, she's exclusively formula feeding. And in her visit with her pediatrician, she breaks down crying because she feels guilty that she can't breastfeed even now that the baby no longer has NAS. So I want to ask a question here. Dr. Pratt-Chavez, does this make you think of anything? And I have not talked to Dr. Pratt-Chavez about this case. And so, yeah, so just that's a caveat. This is not set up.
Yes, well, we're missing something.
Yeah, we're missing something.
We're missing something here because she is operating under this assumption that she can't put the baby to breast, or she doesn't want to put the baby to breast. So we need to figure out what's happening there. And so it does make me think of trauma.
Yeah.
Yeah.
And so, like I said, I haven't set this up, I promise. But, we're missing something. She says she wants to breastfeed. She's asking for help. But then when help comes, she's pushing back.
Mm-hmm.
And this is a real case, by the way. Not a case I had, but a real case from the literature. So in the ensuing discussion, she tells the pediatrician she was sexually abused as a child. And she talks about how whenever the baby's breastfeeding, she really has these intrusive thoughts. And it brings back some PTSD, and she feels really uncomfortable with it, especially because it feels good to have the baby to the breast, and that feels really uncomfortable to her to have this close relationship with her child, and especially with her breast, which have, she's been violated. So, and she had a lot of PTSD right after the delivery, triggered by her vaginal bleeding. And like I said, a lot of feelings of discomfort when the nurses or her baby touch her breast, when people are walking into the room and she's breastfeeding, especially when men are coming in the room, and it's really hard. So the pediatrician referred Ms. Smith to a therapist, and the pediatrician talks to the lactation specialist and gives her the heads up and says, this is what's going on, and picks a lactation specialist who she thinks may be better at working with this mom. And ultimately, Ms. Smith finds that by working with these folks and reminding herself that breastfeeding her baby is quote unquote not perverted, and these are not my words, these are the words from the mom. And she finds that she's breastfeeding in a private, safe place, and she literally has to close the door to a room, that she's able to resume breastfeeding. And she comes back 2 months later, and 2 months later, and the baby's exclusively breastfeeding and doing really well.
What I like about this story too is that although she's out of the hospital, and this was her visit when the baby was a week old,
2 weeks old,
2 weeks old, we still can help her with breastfeeding if we figure out where the barriers are and address them.
And that's a good take-home message really for any mom with breastfeeding, is that although we emphasize the importance of skin to skin and latching in the first hour, and we emphasize the importance of not giving formula supplementation, and all these things are true. I mean, it definitely decreases your chance of being successful at breastfeeding if you don't have, you know, skin to skin contact and you don't have breastfeeding in the first hour, and if you do supplement, but it's not a lost cause. It's really not a lost cause. So these are some barriers that breastfeeding moms who have substance use disorder may face, and there's a lot of them. So they've got a disproportionate likelihood of having a mental illness. Up to as high as 45% may have experienced sexual abuse, and that number really blew me away. I mean, that's half. I mean, let's just round up. That's half, or physical abuse. There's this tendency I've read in the literature of these moms to kind of take it personally if the baby doesn't latch on well or cries, of really taking it personally. And, you know, I think that may be a little bit of a, I don't know, I think it may be a defensive mechanism, and also just, you know, these moms have been through a lot and don't have a long history of people being particularly nice to them. It's interesting because I read this in the literature, and if I recall, I believe you and I talked about this before. Have you seen this?
Sure, where they'll say when the baby's struggling to latch that the baby doesn't like me, or the baby doesn't like my milk, or he hates this, he hates me, and so they see rejection in the baby's struggle with breastfeeding.
And it's really sad. I mean, this to me is in some ways maybe the most heartbreaking thing, and it's not just specific to breastfeeding. It's just about that relationship at all. But again, this is something we need to be paying attention to, both with respect to breastfeeding and then just supporting this mom as a parent. Period. A lot of misinformation about the safety of breastfeeding and either smoking. I'm sorry, this was supposed to be moved over. So the safety of breastfeeding and smoking. Some of these moms think they can't breastfeed if they smoke. Fear of breastfeeding with opiate replacement therapy, and fear that the baby might overdose or might get high. Hepatitis C, we kind of already brought up. Other medications, including like antidepressants, and the baby with now this should not be the misinformation anymore, but babies with neonatal abstinence syndrome, these are hard babies. They're hypertonic, they cry a lot, they want to suck all the time, they have trouble organizing their little bodies, they have a really hard time, so they're extra hard babies to feed on top of all the other barriers the mom is facing. And low socioeconomic and educational status, and I didn't just pick this up, this is from a study. I mean, on average, not all people using drugs, of course, are going to be low socioeconomic or low education, but a disproportionate number of these moms are coming from that background, and this is a group of people who are already at risk for not being successful with breastfeeding. And there are more barriers. I hate to say it, but this takes 2 slides in small print. There's also separation. I mean, we're in a lot of hospitals these days going to the NICU. If your baby goes to the NICU, it's really difficult to establish breastfeeding and be successful at it. The need to get methadone dosed daily. If you've got to go to get your methadone every day, you're apart from your babe for many hours. Sorry, this came back in. This is I was hoping to clean up. Lower threshold for discomfort and difficulty. I mean, a lot of these moms, again, for a variety of reasons, adverse childhood events, etc., just have a little less patience and a little less ability to kind of work through some of these issues. Some of it may be, I think, that when you're addicted to opiates, your pain threshold tends to be much lower, right, from what I've read, and so that's probably playing into it. Lack of support. Go ahead. Yeah.
And I think part of that there would be problem-solving skills and coping skills. They're already under stress with substance use disorder, and then with a neonate, and then if you're in the hospital, and so you're trying to manage your health with your substance use disorder, then underlying that is probably some impairment in coping skills and problem-solving skills to begin with. So it can be really challenging for these moms to be their own advocate.
Yeah. And then, of course, they don't always get the best support from their families or their partners. And unfortunately, they don't get the best support from us often. So, and this was really a theme when they talked to women in a couple of the papers I looked at. When they talked to women, they said again and again, especially postpartum nurses. Less so their prenatal providers, which makes sense, especially if you're in a program like Milagro. You have a close relationship with this mom over time, versus the postpartum nurses don't have this previous relationship, maybe don't have as much experience with these moms, and they're seeing the baby, and they're seeing the baby suffering, and there's this tendency to be judgmental. So oftentimes there's a lot of lack of support, and this can be secondary to misinformation. So the nurse believes that it's unsafe for the baby to breastfeed if the mom's Hep C positive or taking methadone. Hospital policies. I mean, a lot of hospital policies are going to get in the way. I mean, you have to craft your hospital policy carefully in order to both protect the baby and protect the mother and protect this relationship. Prejudices. I mean, you know, we have prejudice. We have to look within ourselves. And then these can be more difficult moms and more difficult families and more difficult babies. And so, you know, it really, but it's kind of like the relationship between parents and kids. We are the adults, right? When you think about your own kids, you have to be the adult. So we as healthcare providers, this is our role, and we have to step up to the plate. This is our job.
Yeah, to be a leader and an advocate for these families.
Yeah. And recognize, and I think, you know, so I think how can we support? How can we improve our own practices? Well, we got to educate ourselves and our colleagues. We're trying to do that right now. And we really need to be discussing breastfeeding early with the mom and when it is and isn't safe for them to breastfeed. So I think it's unfair if we're not giving the mom a clear expectation and nobody says, hey, if your UDM comes up positive for marijuana at the time of delivery, they may not let you breastfeed. We need to be upfront. Moms need to know that the rule, you know, they need to know what the rules are. They need to know what the rules are. So we need to have clear policies that are communicated to everybody on staff and to all of the moms that are in pregnancy. And then again, we need to recognize and control our own biases. And I freely admit that this is, you know, I have to check myself sometimes with a family, whether it's with opiate use or any family that's quote unquote more difficult to deal with. You have to really take a deep breath and say, okay, what's my job? How can I make this better? And what am I missing? You know, what am I missing? Like we talked about earlier. So, you know, we also need to be encouraging and positive with these moms, with all moms, not just these ones. And we need to be doing more about asking about this history of sexual or physical abuse, because if we know that, then we can really address those things. We can ask before we touch mom's breast. We can limit the number of providers that are coming into the room. These are probably not the greatest ones. If you have a mom with a history of sexual abuse or something, probably don't need to bring 3 medical students into the room. We can accept that mom may need some time to become more comfortable and give her that time. And to the extent available, and this is a harder one, we can seek to find trauma-informed providers. All right, so now we're going to get back on the different drugs. So what if her UDM was positive for marijuana? What else do you want to know? I'm going to kind of flip through this because this isn't interactive. So have her UDMs be positive throughout pregnancy. That'll be a red flag if she's using all the time. How often is she using THC? And it's kind of interesting, not too long ago I had a resident and they came out and they told me that the mom's UDM was positive for marijuana. And I said, well, did you ask her how much she's using? And he said, no. I said, yeah, you have to ask her. And he was so uncomfortable. He was going to have go over this conversation. I said, no, really, it's going to be fine. You know, moms appreciate when you take the time. And I find that most moms are not at all threatened. They appreciate taking the time. They appreciate the information. And you have to do it. Regardless of how uncomfortable it is, you have to do it. And do you have a reason to believe this was an isolated relapse? So call up her prenatal provider. Perhaps her prenatal provider can say, you know, she's never done this. I know her father just died last week. Maybe that's it. You know, so don't just isolate yourself and work within a silo. Reach out to people who may know her better and ask her. And what does her prenatal provider say? So marijuana is a lot in the news these days because it's becoming legal in a lot of areas. We have a lot of pregnant moms who are turning to marijuana, not necessarily the moms with opiate use disorder, a lot of moms without opiate use disorder choosing to use marijuana for their nausea. But of course, this group of moms also. This just came out, and this is a very busy slide. Don't try to read it. October 2017. And basically what they're saying is we should be discouraging moms from using marijuana, and we need to have a conversation with them. If we don't say anything, they don't know. Again, they need to know what the rules are. And we should not be encouraging them to use it. And I assume this comes from the fact that there are providers out there who are saying, sure, smoking marijuana will help your nausea and it's okay. And you know, there's not great literature out there, but from what there is, we have reason to believe it's probably not the best thing for brain development for babies. And so it's the OB-GYN or the midwife or the family medicine doctor to have that conversation and let moms know it's not okay and to not encourage it. So again, a busy slide. I just want to say, and this is during pregnancy, but of course your brain keeps developing after you come out as well. The endocannabinoid system is present. So we have receptors in our brain for marijuana. And a prospective study using neuroimaging found fetal growth restriction for moms using cannabis throughout, and increased frontal cortical thickness among school-age children. I don't think we know what that means. The bottom line is it's affecting them. There are anatomic things we can see, kind of like with fetal alcohol syndrome. You can see on their face what's there. So there is something there to see, even if we don't understand the impact, which certainly leads us to believe it's having some effect. We may not know the full impact, but it is having some effect. And I bring this in because of the fact that it is illegal in Colorado. It's legal in Washington, right? Yeah, it's medical marijuana is legal in New Mexico. So think about those of us who are in our 50s. We came of age in the 70s. The perceived risk is blue. Use is red. So perceived, oh no, I take it back. This is the use of marijuana. Sorry. Blue is the use. Red is the perceived risk. In the 1970s, it was no big deal. Everybody smokes marijuana. It's not going to cause any problems. Well, lo and behold, when perceived risk is really low, people tend to use more. So then in the 90s, perceived risk was really high and the use went down. So here we are, and perceived risk is going back down again. And I can only assume the perceived risk is going down because it's becoming legal. As the perceived risk goes down, use goes up. So this is going to be something we're going to keep on facing. This not so much other than to say that marijuana is going steady, cigarette use is going down. So thinking about some of the pharmacokinetics real quickly. So marijuana, what are some of the pros? It's really bound to plasma, 99.9%. It's hooked onto mama's proteins. Volume of distribution is quite big, relative infant dose is quite small, but it's really lipophilic. It loves fat. It likes to store in fat. What is breast milk? After the first few days of colostrum, it's fat. Milk to plasma ratio, this is the only thing you really need to know, and I should put this in red, can be up to 8-to-1 in heavy users. What's a heavy user? As far as I can tell in the literature, the best definition is using every day. So if you have a mom who's using marijuana every day, you probably don't want her breastfeeding, because 8-to-1, that means that if it's mom has this effect, they do that 8 times the effect. That's scary. And babies' brains are going very rapidly in the first year or two of life. So this is really the take-home message. If you're a heavy user, you probably shouldn't breastfeed. It also has a really long half-life. LactMed has a lot of stuff, but occasional use, probably no discernible effect. Okay, so preferable to encourage moms to use marijuana to continue breastfeeding while minimizing infant exposure and trying to get the moms to reduce marijuana use. The daily use and the motor delay, this was a really soft call, a study out of Jamaica. I've read that study, not impressed. Hale is a little more conservative, Dr. Hale, and he says basically, there's an increasing concern. Again, some of the literature I was telling you about with the changes, and it can really change the reward system, maybe setting these kids up for addiction later. And it should be strongly discouraged. But again, for single or infrequent exposure, breastfeeding can continue. I disagree with you after 24 to 48 hours, but that's what he says. So basically, depending on family circumstances, you got to weigh the benefits and the risks. And if mom's not a heavy user, I think the benefits really outweigh the risk. If she's a heavy user, probably the risk outweigh the benefits. And each institution, again, should work towards a policy, because you're going to have different populations. And so for one population, it may be more of a problem than for another population. So our guideline, what we decided, is breastfeeding is generally going to be supported if moms have a history of occasional use of alcohol or marijuana, and who either quit when they discovered they were pregnant, continued to use occasionally in small amounts, not every day, and either plan to quit or plan to continue to use small amounts and not every day. I don't tell parents that. I don't say it'll be okay if you use a little bit amount. I really go into a lot of detail about why we're concerned and what we think the effects can be on the brain, and really discourage marijuana use. And I do say that if they're starting to use, especially heavy, they should stop. But there's quite a bit of wiggle room there.
I think it's also helpful to ask how they're using marijuana and what they're using it for, and are they treating themselves for something that we can use a different medicine for that's safer.
I'm glad you brought that up. And again, we did not have this conversation, but I'm actually glad you brought that up. I had a mom not too long ago who was on medical marijuana for these terribly debilitating headaches that she'd had since she sustained a traumatic brain injury. And when I really sat down with her and talked about, these are our concerns, this is what we're worried about, this is what we think can happen, and, why we would like for you to not use it now, she really appreciated the information, and she said, I'm going to really try not to. And we talked about using other things for now, even though they haven't been as effective, they're somewhat effective. And I encouraged her to breastfeed and said it was okay, put an order on the chart, and felt like I trusted that if she started having bad headaches again and they weren't controlled and she needed to start using daily again, that she would stop. And at some level, our most important job is to talk to the families, give them as much information as we have, and document. That's kind of a lesser one, because especially on my unit, they're only in the hospital for a couple of days. They're going to do what they're going to do when they go home. But even for the moms who are in the hospital for a lengthy period of time because their babies are withdrawing or something, they're still going to do whatever they want to do when they get home. And I think we have to be careful. One, we really do want those moms who are doing it safely or not a risk to their child. We really want them to breastfeed because it's really going to help their baby. And it's really going to help them potentially, especially this group of moms. I mean, I feel like breastfeeding is great for everybody, but most important for, premature babies, and most important for babies whose moms have already had a lot of adverse childhood events and have already a lot of hits against them, because consequently the babies have a lot of hits against them too. So just a little bit more. So this is just talking about what I said. So again, if the screen is positive, that doesn't preclude breastfeeding. We need to document, okay? We need to document why we think that it's okay, and we need to really counsel mom. So what if she's also using, how are we with time? Good? Okay. So what if she's on all these other medications, and I'm only going to talk about sertraline. Sertraline is Zoloft, antidepressant, SSRI. She's on Zoloft for her depression. She's on albuterol for her asthma. She's on Claritin for her allergies. She's on ibuprofen, and she takes her multivitamin. So medication use during pregnancy, lo and behold, has gone up over the years. Okay, so at any time during pregnancy, 50% of moms are taking 4 or more medications. So this is not uncommon. The more troubling ones are you're taking an SSRI, you're on methadone, and you're on Depakote or something. And I would, I guess one thing I would say is that I invite anybody in the state, if they have a question, they're welcome to call me. I mean, I may not be able to answer it with 100% knowledge, but I can certainly help them to sort out their problems. I've had to do it quite a few times. So what do you think?
SSRIs are safe for breastfeeding.
SSRIs are safe for breastfeeding. I love this. Again, it's busy. All I want to tell you is green is untreated depression. Okay? Green is untreated depression. Untreated depression is not good for babies. Okay? Hyperactivity, inattention, worst if you're untreated. Conduct problems, worse if you're untreated. Emotional symptoms, worse if you're untreated. All your difficulties, worse if untreated. Red is unexposed. So that means mom doesn't have depression. Okay? So mom doesn't have depression or the mom's on an SSRI. For hyperactivity and inattention, it's equal. Mm-hmm. Yes, for conduct problems, it's a little bit higher. I don't know that we know, if that's a genetic predisposition. I don't think we know the answer to that, but clearly untreated depression is not good for babies. That's the take-home message. I apologize. That should say serotonin. Can they go down? Huh? No. Anyway, SSRI-related symptoms. So babies whose moms used SSRIs during pregnancy, afterwards, often have some of these symptoms: tremors, jitteriness, irritability, hypertonia, excessive crying, sleep disturbances, tachypnea, feeding problems. What does this all sound like?
Just sounds like opiate withdrawal.
Sounds like opiate withdrawal. Yeah, so they will present pretty much exactly like a baby who's withdrawing with opiates. So this definitely makes, I think, your job harder when you're trying to figure out, do I need to start this baby or not? Some of it's a little bit the timing, but I don't think we get to necessarily attribute it to the SSRI regardless. So yeah, it makes life a little trickier. It occurs in about 30% of babies whose moms used an SSRI in pregnancy. And factors that are going to contribute to the likelihood of symptoms developing: maternal dose. So in this case, that does matter. Metabolism, which SSRI she's using. Sertraline, hands down, is the safest. So if you're a prenatal provider and you're able to start your mom on that one or move her over to that one if you have enough time. Individual drug clearance, genetic predisposition, prematurity, okay? The symptoms are generally going to occur within the first 2 days of birth, and they're self-limiting. So with an SSRI picture, if this is the only thing and you have no reason to believe a mom is using opiates, you obviously don't treat, okay? Because it's not going to help. That's not the problem. This was an interesting study looking at neonatal abstinence syndrome and psychotropic medication. So what about the opioid-dependent mom who also has something else going on, has taken another medication? So we know they've got a higher prevalence, and we already talked about this, of co-occurring psychiatric problems such as mood, anxiety, depression, etc. So we know that. And infants born to moms with opioid dependence and who are taking an antidepressant may have an increased risk of NAS, and they may have a longer hospital stay. So it's just, there's just a couple of studies, but it does, I say may because it's not 100%, but it does appear that there's a fairly good chance they're going to have a little bit harder time. Which again, just makes it that much more important that we're doing all the things. And, this talk is really about breastfeeding, but, when you think about what are some things, and I must not have added it, so I'm just going to talk a little bit about this. One of the studies I was looking at was actually a meta-analysis looking at studies that are looking at different ways to help reduce NAS. And so they were looking at prenatal care that used both treatment of her substance abuse and prenatal care together. That probably helps, and that's the model, of course, we have with Milagros. But I don't think it was met. What's the word?
Medication-assisted treatment.
Yeah, but I'm saying using them together, putting them together. So in other words, instead of having your regular OB-GYN and you're going to ASAP, you go to the Milagros program, where they're going to surround you with this group of people who are really expert at taking care of moms and babies who have opiate use disorder or have substance use disorder. So that's one of the interventions. Rooming in, even without breastfeeding, rooming in is statistically significant for helping reduce NAS, and it makes sense. You're with your mom, and not only are you with your mom or your dad, and hopefully getting more skin to skin, but you're not in that loud, highly lit up area with everything going beep and by yourself. And we know that's not great. So that's another adjunctive treatment. One that was really interesting, and I don't think we have any power over, was split dose methadone. For methadone. So instead of giving it in a dose once a day, splitting it up into 2 or more doses, that was statistically significant for both mom and baby having a better time. I don't have control over that. You don't have control over that. But
And that's the dose for the mother?
The dose for the mother.
Interesting.
That the babies, tend to do better, and the moms tend to do better.
Mm-hmm.
Breastfeeding, of course, was one of them. And I can't remember if there was another one. Those are the main ones. But so rooming in is really important. I mean, and it just makes sense. We, in an ideal world, we would have a unit where moms and babies always roomed in. It was always quiet. You had experts taking care of them, and they didn't go to the NICU, even if for no other reason than just the separation we talked about earlier. So, in summary, I love this slide. Young Women United made this poster. I am more than my addiction, fighting for those I love, fighting for my life. And, we have to remember that these mothers love their baby. I mean, and at some level, the old, there go I, but for the grace of God. And the vast majority of these moms have had a lot of adverse childhood events. They didn't get to where they are in a vacuum. They didn't get to where they are because they're bad people. And we need to really remember that and support them.
I agree. Thanks, Emily.
You're welcome.
Appreciate it.
Yeah. Any last thoughts?
I think that's a really nice place to close. Thanks.
Okay. Great. Thank you very much.